Welcome back to Cath Lab Outreach. My name's Scott. This week we're going to talk about heart cath. When you talk about heart cath, the word heart cath kind of brings a lot of different things to mind. Kind of depends on how you're approaching this. If you're a patient and you just searched heart caths because you're getting ready to have one, you want to see what you're getting yourself into, that brings you from one certain perspective. But you also may be someone who's looking to get into cath lab work, or someone who is sending their patient to the cath lab. From EMS, the most direct route into the cath lab is via a STEMI, which we've talked about in other videos. But if you're a patient if you have an ER patient, or if you are on the floor working and you're getting your patient ready for a heart cath, what does that actually mean? How are you going to educate your patient? Well, this one closest to me here is a right heart cath. Now, this program is RHC Mentis. It's an app that you can buy for iPads, maybe some other applications as well, but I use mine on the iPad to teach with. That's a fantastic tool. Mentis does a lot of things with simulations for a lot of the cardiac industry, as well as some other industries, I would imagine. So this is an all venous approach. And what you do, this one here is IJ. You could go brachial, you could go femoral, but you're trying to make it to the right atrium and follow the blood through. So this is a video of a swan. There it is. Just past through the tricuspid into the right ventricle. There it goes through the pulmonic into the PA. You see your waveforms changing at the top. And then once you get it wedged in the smaller part of the arterioles, you see your waveform change again. We'll talk about right heart cath on a different video, but that's all venous. And you can look at valves and pressures in the heart, pulmonary hypertension, volume overload. All of those things can be monitored very close. Cardiac output can all be monitored very closely with a right heart cath. The other two, the angiograms, are a left heart cath. So when you talk about left and right, you're talking about sides of the heart. So the left side of the heart is your high pressure side. You go in through the arteries, make it to the aorta, and that's where you access your left coronary artery, which is your left main, which is this middle video, and then the other video is your right coronary artery. Some people get tripped up when they say, if this is a left heart cath, how did you see my right coronary artery? Remember, the right heart cath is all venous, so you're looking to follow blood through the chambers of the heart. The left heart cath is looking to find the aorta, find your coronary arteries and study those. And you can also go through your aortic valve and study pressures in your left ventricle as well. Remember, we are 3D people, and this is a two-dimensional screen, so the camera will move around for different views. Remember, these are also epicardial leads. So if you think about my fingers on a ball, if I said, how does my first finger look? Well, you wouldn't be able to see it because all these other fingers are in the way. Same thing with the heart. These vessels are on the surface of the heart, so they can overlap very easily. So that camera has to spin to give different views. What looks thick on one way, actually, when you spin the camera, might be very thin. It might be compressed. So you have to get multiple views to understand exactly what's going on. This is an example of a right heart cath. This was that previous STEMI that you saw. And the first video is a wire going down, and you see that clot in there. That clot, let me get you a little marker here. That clot actually has that gray look to it. So the wire got through. This is a stent being blown up. They just step on the pedal just for a minute to record this being done. And then here's that same right coronary artery finished up. And you see how good that actually looks. So what's the process of having a heart cath? Well, first off, you have to break into the body. So remember, and this video, we're primarily going to talk about left heart caths the rest of the time, but you need a sheath. So what's a sheath? Well, all it is an IV catheter, except where fluids would normally hook up, this actually has gasket there, and you can actually pass wires and balloons and stents and catheters through that. These also have a side sheath that comes off, and that's where you can actually flush it, give certain medications within the procedure. Where are we going to get access? Well, first off, the old school way was always femoral. Radial has only been going on the last 20, 30 years, but now most places are greater than 50% radial approach. And we'll talk about that here in just a second. But a lot of technology has improved and the number of complications have gone way down. The use of ultrasound has tremendously helped this whole process as well. So when you talk about where are you going to go with this, why do we pick where we do in the leg? Well, remember, first off, if we need the artery, we have to find it. They're easier to find because they're pulsating, but the order is always the same. Going from lateral to medial, you can spell Navy. So nerve, artery, vein, the legs make a Y. Nerve, artery, vein, the legs make a Y. And that's an easy way to remember where things actually are. Whenever you feel that arterial pull or that femoral pulse in the artery, you know that medial is where that vein would actually be. So why do we stick where we do? Well, you want to stick over the femoral head. And you have this inguinal ligament that runs just over the femoral head. And below that, you'll have this bifurcation. So your perfect site for a femoral stick is between the bifurcation of the superficial femoral artery and the profunda and that inguinal ligament. Because this actually is deep in the body and it surfaces to come up on this little plateau here. So on that plateau is where it's actually above a bony process that you can actually hold pressure and get control of that artery or that vein once you've accessed that. But once it goes above that inguinal ligament, now you're actually going down toward that retroperitoneal space. So a high stick means it was stuck above that inguinal ligament, which can't be seen on x-ray, but it is inferred where it is based on the femoral head. And with angiography, you can study that too. So here, this oblique view here in this bottom corner shows how those vessels surface up to that plateau. They're on the plateau over the femoral head, and then they go back down into the retroperitoneal space if you're heading inferior to superior. So when you talk about radial access, then you're talking about a little bit safer approach. There's more stimulation in my opinion, because when you go through the leg, all they do is numb it, and then you'll feel the pressure of the sheath going in. Remember, the numbing medicine takes away the sharp sensation, but can't take away touch. So here, your radial or ulnar gives you good options for your arterial approach, and brachial is a good option for a right heart cath. Usually, flow in the hand is assessed. You want to make sure it's a good radial with backup flow to make sure that hand is safe if there was a problem with that artery stick. I say there's more stimulation on when you go radial or ulnar because of the medicines that are given through there to prevent spasm. One of the things that can stop you from going through the radial artery is when you get in there, there's a lot of spasm with that, and they can actually lock down on that catheter. Usually the patients don't remember that much because they've had Versed or fentanyl and other things, but there's different tricks to try to loosen that up, break that spasm. Most places give a heparin, a nitro, and a verapamil cocktail. I'm sure there's several other places out there that do different things. Versed will help relax the patient and help break that artery, that spasm. You can also put a blood pressure cuff on that same arm and blow it up, leave it up for a few minutes, and that will cause the artery to dilate and release that catheter. It's pretty rare that complication happens. It's more painful than dangerous, but once that's out, all that pain goes away. Another approach that different places will use is this distal radial. And here we see your primary site, that ventral approach. But where it actually comes back up over the wrist, you can actually have your hand, if you went left radial and everybody's on your right side during your procedure, that patient can actually put their hand over top and just lay it instead of having their wrist turned. They can actually just lay their hand very comfortably, and they can actually access that in that snuff box. And that's called a distal radial approach. If we find a block that needs fixed, it has to be greater than 70% to require a stent. So here we have our artery, we have the plaque on the inside, and this would not be a STEMI. Remember, if this ruptured and what's inside the plaque is revealed to the body thinks it's bleeding to death and sends those platelets and clot to that area. But If we just have a 80% blockage in here and that's causing our problems, then you can actually go in and blow a balloon up. So they'll put a wire across it first. They'll blow a balloon up, and that balloon will stretch. There's two different types of balloons, compliant and non-compliant, two primary types, compliant and non-compliant. A compliant balloon will comply with the wall. It's more like a balloon animal. If it's whatever, it'll conform to whatever shape is in there. So usually the compliant balloon is done first, and that helps you visually assess if you've got calcium or something else that's in there that's very hard that will have to be treated before the stent can be placed. If this is all soft plaque, the balloon will be nice and oval because there's nothing there to stop it from expanding. And then once they have it prepped to the extent that it is required, they'll actually put a stent in. So the stent rides on a balloon, it blows up, the stent locks open, the balloon collapses and comes out. When you talk about stents moving or stents collapsing, that's not really exactly what's happening. There are disease processes that will cause a stent to clog back up, but once the stent's there, it's there permanently. And we'll talk about here in a minute what the body's going to do with it. But you want those edges to be opposed. That means they are pressed, all the edges are pressed into the artery wall or up against the artery wall. So the compliant and the non-compliant balloons are balloons that ride on this catheter. They're a part of the catheter actually, and they'll go in. They'll have radiopaque markers, as you can see here, and those will actually let the provider know where they are in that artery and blow it up exactly where they want. The more pressure they put in, the higher the larger the balloon grows. Your compliant balloons will grow greater. Your non-compliant balloons will grow, but they get firmer. They're a harder type of material, and they're actually good for reshaping stents, expanding stents, pushing that metal around. Whereas a compliant balloon more lets you see what inside the wall there, what are we actually be dealing with inside. So when you think about this, this is atmospheres. So when you take this atmosphere, so to know your PSI, how tough these vessels are, you're actually, that's 14.7 at sea level, 14.7 times that amount. So you can get up to where you're over 200 PSI pushing against the walls of those arteries. You know, the car you drove in today had pressure in its tire. The pressure pushing against that wall was probably between 35 and 45 PSI. Here, we're going to push against that arterial wall with 200 PSI, which tells you how strong these arteries actually are. So when you put a stent in, what we're talking about is leaving a metal scaffold behind, and that's going to actually hold that vessel open. So most stents now are drug-eluting. That means they have a drug on them that is kind of like a candy coating that prevents the body from scarring and overgrowing that stent. Remember, this is a foreign body, a metal object in the exposed to arterial blood. The body's going to try to hide it first, so it's going to try to throw clot on it. That's why during the procedures, it's very important that we have heparin or angiomax, some type of blood thinner on there to where clot cannot build. We could cause a worse heart attack or a stroke. So they have to be anticoagulated for the procedure. So that alone right there eliminates some people for it. What if you have somebody with a head bleed and a STEMI? What are you deciding here? Really, you're deciding where this patient dies. So sometimes just because you are having a heart attack doesn't mean you're a candidate for this type of procedure. If the blood thinner is going to kill you, then maybe it's better to treat you medically for the heart attack and try to see you through the other ailment. So the type of drugs that are here, we talked about being anticoagulated during the process, but until that body scars it in safely, it's still going to be exposed. So you'll be on your patient will be on an aspirin and an antiplatelet. So the Brilinta, the Effient, and the Plavix are by far the three that you see the most, along with that aspirin. There are studies for trying to change that, but right now that's the industry standard. And that's called DAPT, dual antiplatelet therapy. So what kind of medicine's on the stent? Well, I always thought before I got in the cath lab, hey, this will be some type of something to prevent clot, something to stabilize the cholesterol in the plaque. It's actually a cancer drug, and that prevents that body from overgrowing too quickly. As those epithelial cells grow in sheets, this prevents that from growing the whole thing, filling it up with scar and causing that to close back off. So the drug-eluting stents are pretty much the standard as well. So what about care for these patients? If you are sending your patient to the cath lab ahead of time, the consenting part is not your issue, but there will be a consenting process done for this. You want a working IV. If you're placing an IV, avoiding that wrist area is important because that's where that radial access is going to occur. Pre-medications, of course, these are based on orders or protocols, but a lot of times you'll see aspirin, Valium, Benadryl, atorvastatin given. We want to hold those heavy hitter blood thinners to make the whole process safer. So why can I give aspirin and not Coumadin or Eliquis? Well, because those work in different ways. Remember, your aspirin and your Brilinta, those are antiplatelet, whereas these work in the clotting cascades and stop all types of bleeds. So those are considered more dangerous and are tried to be held for at least 48 hours. If you're on those and you're having a heart attack, then they're going to try to go a radial approach. I always tell our patients we need them naked under the gown. That way we have access to the radial approach and the femoral approach very easily. Afterwards, things to think about is IV fluids to flush the kidneys. Contrast can be nephrotoxic, so you want to protect that. Monitoring vital signs. You want to assess for bleeding that you can see, and internal bleeding as well. If they got a lot of large stents, and when you talk about a large stent, you're talking about a 4 or 5 millimeter stent. That's a huge number in the cath lab world. But that chest pain that they have should improve. It's not uncommon to have some chest pain while we were stretching everything, while that balloon's inflated. It restricts blood flow past that. So it's not uncommon to have chest pain afterwards, but it should not get worse and should steadily improve as that afternoon goes on. Things about positioning are very important. If you went through the femoral artery, head on the pillow, and the affected leg straight is what I teach the patient. And then if we went radial, I try to prop that up with the pillow and tell them to keep that wrist in contact with the pillow while they're recovering. Indications of that femoral bleed, which is typically more dangerous than that radial. The radial is observable and compressible. It should be easy to stop a radial artery bleed. Femoral can be a little bit tougher, especially depending on the patient's body habitus. But hematoma is usually your first thing that you'll see, and those hematomas can get quite impressive. So we want to hold pressure as soon as you note bleeding. New low back pain could be an indication of retroperitoneal bleed. So we talked about that high stick. If they have a high stick and now it's leaking from there, that's going to go in that retroperitoneal area, and they're going to have that low back pain. A lot of these patients have back pain all the time. So how do you differentiate? So it takes a good clinician to do that, and they're going to end up heading for a CT scan. But you can ask them, is this the type of pain you always have, or is this something different? A lot of times when you're holding pressure, you'll have a vagal response, or if they're getting a lot of pain in that site, you'll get compression of that vagus nerve, and they'll have a vagal episode. That can be very dramatic, but normally that will pass. Vagal responses are benign, but if it's caused by the bleeding, that part will not be and needs to be assessed. And you could have loss of distal pulses, especially with some of the closure devices we'll talk about here in a little bit. Knowing your pulses before and after are very important. What do I do if I see a bleed? Well, hold pressure. All bleeds, hold pressure. There's nothing magic about it because this was a heart cath. If they're bleeding, hold some pressure on that. You want to think about where to hold pressure though, especially your femoral. The radial artery isn't quite as hard. It's a lot easier, smaller area. It's easy to compress. Your femoral artery can be a lot harder. So you want to see where the arteriotomy is, which will be just superior to where the needle stick is. Because you think about it, if the artery's coming down, you're sticking in the skin, then you make it to the artery, and you're heading up. You're heading in a superior direction. So you'd want to hold pressure above where the skin nick was, above that arteriotomy, you want to hold pressure up here. Another good way to do that, to know that you have control, is put some type of pulse ox device on that foot, and then you should be able to see that waveform, hold pressure, and watch that waveform go away. And then you know you have good control of that vessel. This is a type of radial band that's common, and there's a couple of different vendors out there, but you'll have a radial band, and the needle stick area will either be right in the center of this or in the distal third, depending on the manufacturer. They have different recommendations, but regardless, it's just a matter of holding pressure. But you do want to feel a palpable pulse distal to this. So if you have no bleeding over the site, but a distal pulse is palpable, you know you have patent hemostasis. Blood flow is able to still perfuse the hand, bring in clot, bring in platelets, fibrin, that type of stuff, but it's still tight enough that you're not bleeding. Different bands are out there for that distal radial as well. This is a good example of where that distal radial site actually is, but you'll have specific bands for that as well. And then finally, if you do go through the femoral artery or veins, you can close these up with different devices. These have different indications, but the angioseal will leave a foot plate behind. The body will absorb over the next few months. Perclose is actually a suture-mediated closure. The Minx is extravascular. It'll leave a collagen plug, and then Vascade has an indication for artery and venous with different devices, and that'll leave an extravascular plug as well. Closure devices are nice because they decrease the amount of bed rest the patient has to have, but they can fail at a later time. If you're just holding manual pressure, when you let go, if it's bleeding, you know it and you hold more pressure. Here, these can give you that false sense of security that, oh, it has a closure device, and then fail later. So that is rare for them to fail later, but it can happen. So good assessment is very important. That's kind of Heart Cath 101, and we'll pick a couple of these areas and we'll expand on those in the future. I hope this was helpful.